Good morning, everyone. I hope you can hear me. My name is Dr. Iskandar. I'm an infectious disease consultant in the Faculty of Medicine, University Malaya. And I'm very pleased today to be joined by several presenters who will be sharing to you on topics related to HIV treatment cascades and the 95-95-95 targets. This series of presentations is brought about really in celebration of World AIDS Day, which happens every year on December 1st, really to commemorate and remember lives lost from HIV and to celebrate the successes of HIV treatment that has occurred over the past years. Now, really, the theme today is understanding the 95-95-95 targets and how we can improve both testing, treatment, and retention in care and viral suppression in people living with HIV. Now, I'm going to be starting by talking about really understanding those targets, and I then will be followed by Dr. Afiqah from the Social Preventative from Department of Social and Preventative Medicine here in University of Malaya, will be concentrating on the first 95 and HIV testing approaches and strategies, followed by Dr. Sazali, Basri, who's an infectious disease specialist in our department, who will then be talking about the second 95 and talking about strategies to improve and identify the gaps around linkage to care and retention in care. And then concluded by our very own Nurrul Sakinah, who is a HIV nurse counselor who'll be talking about the ID Wellness Clinic. So just to start off, in the interest of time, I'll go straight to my presentation. Okay, so once again, I'll be talking about understanding the 95-95-95 targets, and this is basically around HIV testing, treatment, and viral suppression. So just to start off, I'll introduce the topic by talking about the overview of HIV epidemic in Malaysia. As you can see on the graph on the left, the HIV epidemic in Malaysia has really shifted from that of an transmission within injecting drug use to that over to sexual transmission over the past 10 years. This has largely been due to the successes in the public health programs centered around harm reduction, involving scale-up of needle syringe programs and opioid substitution therapy, which has led to reductions in HIV incidence within people who use drugs. So much so in that 2022, 96% of transmissions occurred as a result of sexual transmission, of which 60% of this occurred between men who have sex with men. Looking at what's reported on the right, we have about 85,283 estimated of people living with HIV, and this is data till the end of 2023, as reported by the 2024 Global AIDS Monitoring Report, of which we've been having on average about 3,000 infections on an annual basis over the past 10 years or so, and this hasn't changed very much. And now we have about 50,000 people living with HIV who are receiving antiretroviral therapy. So what are the 95-95 targets? Now, these are targets which have been set by the United Nations since 2021. Really looking at three indicators: HIV testing, those who start treatment, and those who maintain on treatment and have a viral suppression. So the first 95 essentially is looking at or aiming at targets which are defined as at least 95% of people living with HIV knowing their HIV status. The second 95 is defined as at least 95% of people who are aware of their status are on treatment. And the third 95 is at least 95% of people on treatment who have a suppressed viral load. Now, the advantages of using the 95-95 targets essentially is that it tells us about how well HIV treatment programs are doing in terms of right from testing to treatment to being retained in care and maintaining viral suppression. But it doesn't often tell the whole story. Now, looking at 2023 data, the testing and treatment cascade, and how we're making progress on this. So 84% of people out of 85,283 estimated people living with HIV are aware of their status. And so you have a gap of about 9,000 patients who don't know their status. Out of this, 68% of people living with HIV who are aware of their status are on antiretroviral therapies. Here, there's a more significant gap. And once they're started and maintained on treatment, the people living with HIV in Malaysia are able to suppress their viral load, so 89%. Now, how does this compare to the region, our region as a whole? And this is the HIV testing and treatment cascade in the Asia Pacific, once again reported by the Global AIDS Monitoring 2024. Comparatively, we do better in terms of HIV testing, as well as viral suppression. So the first 95 and the third 95. So in the region, only 65% of people who are on antiretroviral therapy are virally suppressed. But we do similar when it comes to the second 95. So although the reported HIV testing is reported as not being too bad at 84%, we still suffer from a lot of late HIV diagnosis. And this is looking at data reported over the years, late HIV diagnosis being defined as CD4 count of less than 350 amongst adults newly diagnosed in Malaysia. So much so that in 2023, 68% of patients were diagnosed late. The implications, of course, of this are is that we will continue to see a myriad of opportunistic infections and mortality associated with late presentation, unless this improves with increase of HIV testing and diversifying HIV testing. HIV is concentrated in key populations in Malaysia, and these are populations which are disproportionate at risk of acquiring HIV, be it female sex workers, men who have sex with men, people who inject drugs, or transgendered women. And what we can see essentially is that over the years until 2022, there's been an increase in HIV prevalence within men who have sex with men. This has decreased in 2022. However, what we can see also in the group people who use drugs, there has been a gradual decrease in HIV prevalence for the reasons that have been mentioned previously. This is not dissimilar to what is happening across the rest of the Asia and Pacific. The distribution of HIV infections is very much concentrated in key populations and the partners of key populations, as represented on the graph on the right-hand side. 79% of new HIV infections occur mainly within key populations. So the problem in Malaysia is largely the second 95. Sazali will be talking a bit more about this, but I just wanted to provide a broad overview of this. And the problems lie largely to barriers to linkage to care and treatment initiation. We know that this is a result of stigma and confidentiality issues, the problems with the testing facility not being able to offer treatment, issues around poor monitoring and tracking linkage to care. And also, once they're referred to a facility, there are often delays in initiation antiretroviral therapy, partly due to issues such as the need for confirmatory HIV testing, which can sometimes be delayed as well. Sometimes in 3 weeks, I'm told, in clinic Kesehatan's, and failure to adopt rapid or same-day antiretroviral therapy initiation. So the current recommendation is to start antiretroviral therapy as soon as a patient is seen following an HIV diagnosis. And once again, Sazali will be talking more about this. In terms of retention, similar reasons, but other factors come into it, such as costs, lack of peer support, long waiting times at clinics, slow uptake or access to novel antiretroviral treatment and drugs, and services not being patient-centered. The UNAIDS have extended the 25-25 targets, not just to include testing, treatment, and viral suppression, but there are also added targets around sexual and reproductive health needs of women, the need for eliminating vertical transmission, and use of combination prevention. UNAIDS also have included the need and the importance of person-centered care and integration with other services, and also set 90% targets for this. Essential to all of this, and I think one of the broadest solutions to some the problems amongst, particularly around the second 95 and the third 95, is to essentially provide person-centered delivery services. And this is where we diversify and adapt HIV service delivery to the client's needs and preferences. So we put patients in the center, they tell us what they want and how we should be delivering it and where it is delivered and how it's delivered, rather than one size fits all. We adopt services and provide services really to an individual perspective, and finding ways to deliver care, complicated care, in a more efficient and in a more efficient way, which meets the client's needs and preferences. Now, working with Malaysian AIDS Council, where Ika and I hold positions there, we're very strong advocates, as well as Dr. Sazali, we're very strong advocates for community-centered, but not just community-centered services, but community-led services. And really, when we think about providing services to the community, we need to let the community design and co-deliver their own services, because they are aware of what services they need. And this is ideally a model that should be expanded to other services beyond just HIV care. But in order for this to happen, so ideally it'd be nice for them to extend services beyond just HIV testing to include HIV prevention, treatment, and care. But we need to view our community healthcare workers as valuable and equal partners in the HIV response. But in order for this to be realized, we need to ensure that there's adequate reimbursement of services implemented by the community, support at a higher Ministry of Health level, and adequate training and certification of community healthcare workers. This is perfectly exemplified in HIV prevention upscale in terms of HIV pre-exposure prophylaxis in Thailand, whereby majority of pre-exposure prophylaxis is provided from community-based organizations. And this increased PrEP dispensing and coverage from about 3,000 in 2019 to 58,000 in 2023. And this was only made possible by dispensing PrEP from key population-led services. You cannot have a talk on World AIDS Day or anything really without mentioning stigma. And this is a slide that I've used many times, and this is some of the work that was done by our team in 2014, reporting very high negative attitudes towards MSM and people who inject drugs amongst 1,296 students from 8 professional schools, using an online survey assessing attitudes of medical and dental students towards people living with HIV compared to those who use drugs and men who have sex with men. The lower scores essentially reflect less positive attitudes and greater stigma. And what we can see on the right essentially is that there is greater stigma towards people who inject drugs and men who have sex with men. This was basically one of our major focus of reducing stigma within reducing stigma as a whole is really focusing on healthcare-based stigma. And really some of the recommendations around this is ensuring that the messaging around U equals to U, and I'll remind everyone that this means undetectable equals untransmittable. And essentially what that means is if people living with HIV are taking treatment and are undetectable on treatment, they are unable to transmit. And if they have an undetectable viral load, they are unable to transmit their infection sexually. And that this messaging gets across to as many healthcare providers as possible, and is also provided the impetus to the change in guidelines, allowing HIV positive healthcare workers to continue working within the healthcare industry. These are just some initiatives that the Malaysian AIDS Council and Malaysian AIDS Foundation have been using to combat stigma in people living with HIV. And so what Malaysian AIDS Council has a Malaysian AIDS Council Care, which is an online communication channel for community members to report any issues around stigma and discrimination to HIV, around HIV and AIDS. And they also work with the Legal AIDS Bureau for legal support. At the Ribbon Gala last year, and this is an ongoing issue in order to protect people living with HIV from discrimination within the workplace. And this needs to change at a higher level, so at a ministerial level. Malaysian AIDS Foundation is currently working with the Human Resources Ministry to amend the Employment Act and the Industrial Relations Act to protect people from with HIV from workplace discrimination. Really, just to summarize things at the end, and some recommendations and interventions to improve the 95-95 targets within the Asian context. Firstly, we need to diversify HIV testing options, including scale-up HIV self-testing. And Ika will be talking about some of the national initiatives and a web and online distribution of HIV self-testing, ensuring that our services are safe, confidential, and high quality, and inviting to the persons that we're trying to reach out. We need to implement same-day antiretroviral treatment, or at least rapid initiation of antiretroviral therapy. There's no reason to delay treatment currently, and access to modern antiretroviral treatments as well. I'd just like to highlight the case example of dolutegravir excess, which is, so in Malaysia, in WHO, what is recommended as first-line antiretroviral therapy is a drug called dolutegravir. It's an integrase inhibitor-based regimen. But unfortunately, Favrins continues, which is an NNRTI, continues to be prescribed. And this is largely related to complicated voluntary licensing agreements. We are unfortunately not doing as well as the majority of the world, including Africa. So 80 to 90% of Africa have access to better oral treatment than Malaysia. And of course, we understand this in the context of complicated licensing agreements, but we need to do better in terms of being able to access the best oral treatment, which in this case is dolutegravir in Malaysia. And we really can't talk about injectable therapy, which is now currently being scaled up in high income settings when we cannot offer patients the best available oral therapy. Just to conclude with my last slide, whilst looking at the cascades, we need to also prioritize disengagement from care. And this is a policy brief released at the IAS in 2024 in Munich of this year, really providing guidance around recommendations on continuous engagement and tracing and sustained re-engagement, and the importance of looking at this beyond the 95-95 targets. So sorry, that was a quick rush through, and I hope I haven't taken too much of my time, and I will pass on to the next speaker, who's going to be Ika, who's going to be talking about the first 95. Thanks very much, Ika. Sorry, can I just say, can we just encourage people to put questions in the chat box as well, and we'll try and attempt to answer them as we go along. Thanks, Ika.
Thank you. Assalamualaikum. Good morning, everyone. Thank you for joining us. Thank you, Prof. Iskandar, for moderating this talk. And it's my pleasure really to be joining this session and to start with the first 95 by sharing how HIV screening and testing efforts have been expanded to meet the first goal. So my presentation today, I'll be talking about the first 95 to give you an overview on where we are right now, followed by HIV testing approaches, with a large focus on the Test Now platform that allows people to conduct HIV self-testing. So in the previous presentation, we've heard about fast-track targets, the 95-95-95 goals introduced earlier, and how we aim to be strategic in our efforts to move people along the HIV care cascade. And a critical focus really is on the first 95 to ensure that 95% of people living with HIV know their HIV status, because only then we can help them transition to the subsequent stages of care and treatment. And without this initial engagement, the entire cascade can be delayed, leaving individuals with opportunity to assess, leaving individuals without the opportunity to assess life-saving treatment and support in a timely manner. So in the Western Pacific region on the far right here, where Malaysia is situated, the current progress towards the 95-95 targets stands at 81, 90, 96, and this is showing us significant strides in treatment and viral suppression. However, the first 95, which is the knowledge of HIV, although high at 81%, remains a challenge, which mirror the trends that we're seeing in Southeast Asia region, which is at 81%, but falling short when compared to the first 95 in Eastern and Southern Africa at 92%. I think in Malaysia, I think we're progressing really well with the first 95, where we have achieved 81% people living with HIV who know their status. And I believe we are right on track, but definitely more work needs to be done for us to achieve the first 95 by 2030. So in terms of HIV testing, ideally what we want to have is to have a service delivery approaches that are diverse enough to ensure people have accessibility to these testing services. One, facility-based testing, which are the traditional way of doing it in healthcare settings. It provides, direct consultation, direct access to professional guidance. And second, provider-assisted referral integrates testing into routine healthcare visits. And the third one would be community-based testing, which reaches out to marginalized populations through mobile units or community centers, and utilizing community members for increased trust and cultural competence, which we do a lot in Malaysia through our community healthcare workers. Social network-based testing encourages testing within social networks and in specific venues where people frequent. Lay provider HIV testing trains community members to provide testing outside of healthcare settings, which is also what we have been doing since 2019. And finally, self-testing empowers individuals with private and convenient testing options. The WHO strongly recommends HIV self-testing as a gateway to diagnosis, particularly for individuals at higher risk who may not be seeking testing in clinical settings. And there's evidence that show that self-testing significantly increases the likelihood of reaching those undeserved populations. And to build awareness and demand for HIV testing, peer-led, innovative digital communications through short messages and creative videos play a crucial role in engaging communities and encouraging uptake. And additionally, focused community-based efforts, including rapid tests delivered by lay providers, especially among our community healthcare workers, are vital to kind of expand access to HIV testing services to kind of ensure timely diagnosis and timely linkage to care. In Malaysia, we've got the Jom Test platform, which is an innovative HIV self-testing platform. And this is part of research done by colleagues, Dr. Hawi Lim and Professor Iskandar himself. And it's designed to make testing more accessible and convenient by delivering self-test kits directly to people who have ordered the self-test kits. So the majority of users from the findings of the study discovered Jom Test through Twitter, either through the official account or shared tweets. So what we've been hearing feedback from end users is that it's been positive, users commenting on how friendly it is, how attractive the interface is, easy navigation, and how it's user-friendly. So most participants have received self-testing kits within 2 weeks, and overall Jom Test has been proven to be both feasible and acceptable in the Malaysian setting. So now what the Malaysian Ministry of Health, in partnership with Malaysian AIDS Council, they've expanded the self-testing platform and have introduced the Test Now platform, which is available through the website and on MySejahtera as well. So it's been officially launched in December 2023, and it's supported by dedicated volunteers to assist with packaging and is also responding to inquiries, while we have program coordinators and officers handle client requests for help. So the platform offers 4 HIV self-test kits approved by the Malaysian Device Authority, MDA. You've got the Insti, Check Now, Be Right, which is through finger prick, and Oral Quick, which is through oral fluid. So to this platform, clients can access free test kits with 2 options. Either it's oral fluid or blood-based kits delivered via postage directly to their homes, or they can have the option of having this stuff picked up at the Malaysian AIDS Council office in Sentul. And this program is being budgeted under the Global Fund, allows one-time orders per client annually, which kind of ensured broad access to HIV testing. So within the HIV self-test platform, which is called the Test Now platform, there are two functions that people can go through. The first one being the risk assessment, and the second one would be to get self-test kits. And these are the questions that are being asked through risk assessment. We were able to find out the birth date and also a last HIV testing done. And we will be able to assess them whether they are at high risk or low risk or medium risk based on these responses, based on experiences, whether people have injected drugs, whether people have used alcohol or drugs before sex, whether people have multiple sexual partners. And on top of that, we also looked at whether, the gender of people, whether they are man, woman, or transgender, and whether people are taking PrEP. Oops. So in terms of risk assessments, between January to June this year, a number of 10,896 assessments were submitted, of which over 6,000 were males and more than 4,000 were females. And when we look at risk behaviors by gender, we can immediately see that the large majority of people assessing this platform reported multiple sexual partners higher in males compared to females. And it is more common in the younger age group, with the large majority of people assessing this platform are within the 26 to 35 age group. Over 6,000 users had never had their HIV test done, which demonstrates how this platform has the potential to attract first-time testers. And among those who had their HIV test done before, it is common to have their HIV test done more than 6 months ago. And when we look at last HIV test by age group, we're seeing that people who have never tested before are the highest among the younger groups. Now, moving on to self-test orders. During the same period, a number of 2,445 self-test kits have been ordered through this platform, with the highest coming from Selangor, followed by Kuala Lumpur. And out of these 2,445 people who have ordered and received these self-test kits, only 270 people provided test results. With 28 test results came back positive. So the Malaysian AIDS Council, through this initiative, what we are trying to do is that we were not able to determine the true positivity rate, as people are not obliged to submit their test results. But we would then encourage people to be in touch with NGOs throughout Malaysian AIDS Council so that we could better facilitate them to move on to the next 95. So in summary, we're seeing that a high number of women and young people have reported using TestNow platform. Therefore, it's showing that it's a trusted platform for these groups to access HIV testing services and also information. And the trend that we're seeing highlights TestNow's potential to provide a safe and accessible environment for women and young individuals seeking confidential health services. It serves as a robust and innovative tool in mitigating the harmful impacts of stigma and discrimination that are often linked to risky behaviors. And having this discrete platform would then prioritize users' privacy, empowering people to take proactive steps towards health without fear of judgment or fear of being exposed. And this approach not only encourages more people to seek testing and support, but it's also fostering this supportive environment, enable environment for people to get tested and to access these services, and in turn to reduce the stigma surrounding HIV and AIDS, be it internal or external. Before I end, I would like to take a moment to acknowledge these key individuals who have worked really hard towards the success of TestNow. People from the sector of HIV, in the Ministry of Health, people in Malaysian AIDS Council, Malaysian AIDS Foundation, and also our volunteers as well. With that, I end my presentation. Thank you.
Thanks very much, Ika, really for really giving us a comprehensive overview of the first 95 and HIV testing with a particular focus on HIV self-testing. So next up, please keep the questions coming in and we'll try and respond them as we go along. Next up, we have Dr. Sazali Basri, who is a senior lecturer in the infectious disease unit here, and he'll be talking about the second 95 and addressing gaps in linkage to care. Thank you, Sazali.
Thank you, Prof. So I hope you can see my slide and also hear my voice clearly. So I will start my presentation with this case scenario. Basically, there's late Mr. K, who at age of 21 years old, he had visited to student clinic with penal discharge, in which he was diagnosed with presumptive chlamydia and also gonorrhea urethritis. During this visit, he also tested HIV positive and thus referred to our ID clinic at UMMC. Unfortunately, he defaulted. Now he's working as a primary school teacher. 7 years later, Mr. K returned to UMMC, gravely ill. He presented with prolonged fever, significant weight loss, diarrhea, and also worsening skin conditions that he had become so severe that he had need to switch off the camera while teaching during the COVID-19 pandemic. So you can see the skin lesions as seen here. His CD4 is only 9, and during the initial admission, he struggled with major depressive disorder beside the initial blood culture, gross salmonella enteritis. His condition later worsens, and he was need intubations due to respiratory stress and diagnosed with rhodococcus lung abscess and also disseminated Mycobacterium evidens complex infection, while the skin biopsy confirmed he had Kaposi sarcoma. Despite the initial treatment, he continued to decline and ultimately succumbed to complications from Kaposi sarcoma inflammatory cytokine syndrome. So this case had illustrated to us how the gap in second 95 after being diagnosed with HIV, patients may not retain care or not linked to care, lead to subsequent adverse events, including mortality. So it's a bit changed in era of effective ART in which patients can live as normal people and also with effective preventive, these things keep happening. So when we're talking about the cascade or continuum of HIV care, I think Dr. Ika had started talking about HIV diagnosis and how we can improve it. We also should talk about HIV prevention. So what my focus will be on about the gap in linkage of care, how to improve engagement in care so that they started ART, keep their virus suppressed, and sustain their health and wellness through preventive medicines. So this had been shown by Prof. Iskandar just now. In Malaysia, we haven't achieved the 95 target yet. 84% had known their status, in which out of this only 68% started ARTs, and once they started ART, we doing quite good, in which most of them had suppressed viral loads. WHO had recommended for quality improvement approach using data to improve linkage. I think thanks to NHQH, after NHQH, we started auditing our service, and this is what we are doing. And I'll share the data on what the UMMC audit is. Thanks to Yasin and Shahni for helping me for collecting this data. So we have done audit at UMMC in which all newly diagnosed HIV in our hospital for the past 2 years. We can see here the median age of diagnosis is about 36 years old, with predominantly males, mainly Malay, with sexual transmissions. And unfortunately, they presented with advanced HIV with median CD4 only 80, with half of them had opportunistic infections. Looking at the 95 targets, so out of 134 clients being diagnosed with HIV, only 72% of them has started ART in UMMC, while about 73% of them were suppressed. So there's still a lot of gap in our, even in our tertiary center. So about the first 95 targets, of course, the data showed that a lot of our clients presented in advanced HIV with median CD4 is only 80s, and more than half of them had opportunity infection or AIDS-defining illness, mainly pneumocystis, pneumonia, and also disseminated tuberculosis. So as Dr. Ika had emphasized just now, there's a lot of things to improve so that we can detect them early and to improve their outcome by improving the testing and also creating the demands of HIV testing, integrated the care through community leaderships, improving stigma, and also create supportive environment as emphasized by Prof. Iskandar, a lot of partnerships, and also leveraging HIV preventions. So about the second 95, as I said just now, only 72% of them had received ART. The mortality rate is quite high, about 70%, because advanced RVD. So mainly during the initial diagnosis, mainly is due to opportunity. The mortality is due to opportunity infections, and also quite alarming, brought in death with newly diagnosed HIV presented to our hospitals. After started ART, the main reasons of mortality is due to sepsis or malignancy related, and one of the clients, our patient, died due to acute coronary syndromes. So about the second 95, 82.2% had disengaged after tested reactive for HIV. They mainly diagnosed at our primary care, Students' Health Clinic in New Stimlaya, even in other outpatient clinics, for example, surgical clinic, especially urology, not because they are presented as urethritis or STI-related infections, but from the audit that we've seen is mainly during the pre-operative screening and also our ENT clinics after they presented with cervical lymph nodopathies. The first visit to healthcare providers will subsequently affect patients' outcome. Role of clinicians in reducing barriers. There's a lot of evidence to show that patients who have just been diagnosed with HIV may be heavily influenced by their first contact with healthcare providers, and the positive therapeutic relationship between the people who are living with HIV and the provider is a key element of successful HIV treatment service. So how can we support them so that they link to care and continue retaining care? So in case using a newly diagnosed positive client, after breaking the bad news, the care that we should provide is stigma-reduced and non-discriminatory. We should give correct information on the diagnosis, the good treatment that's available, and also the prognosis. Subsequently, we should enhance them to case management for treatment and care, and also don't forget, we are not treating the patients in front of us. We also need to think about other patients behind our patients in front of us, which is the contact. Either they need to be screened and the need for post-exposure prophylaxis for contacts. So from the second 95 gap just now, we see there's a lot of gaps in terms of enhancing linkage with case management to ID clinic. So this is something that we will try to improve by providing a fast-track referral to our ID clinic, in which we try to see the patient in the same day if possible, or within the next clinics rather than next available clinics, through our wellness clinic, hopefully with more HIV counselors available in our clinics. Seen by our healthcare providers in the same days after referral can be done. About the second 95, I think just now Prof. Iskandar had talked about the initiation of the ART. WHO had recommended rapid ART initiation, including same-day ART, in which rapid ART initiation means by starting ART within 7 days of HIV diagnosis, while same-day ART is starting ART at the same day of the first clinic visit, in which ART should be offered to all people living with HIV. Why we encourage rapid ART initiations? Because rapid ART initiations lead to better or higher rates of ART initiations, and also improve patient outcome by reducing mortality, improving their retention and care, and also virological suppressions. Is it possible? The audit that done in UMMC, we can see here about 18% of the patients diagnosed at UMMC has started ART rapidly. Same day ART is possible, about 8% of them has started ART during their first ID clinic visits. We see still a lot of delayed ART initiations, more than a week, mainly due to medical reason, in which we try to evaluate for opportunity infection. As you can see here, a lot of our newly diagnosed HIV presented at late stage, in which we need to start or treat the opportunity infection first before starting ART to prevent ARIS. Previously, we will try to start vaccine first, followed with the ART. So there's a lot of improvement in which by concurrent ART initiations with vaccine, we're able to reduce the delay in ART. The things also that we can improve is by improving our diagnostic. For example, Nurrul, in which in advanced RVD is very good tools, diagnostics tool to diagnose TB, in which as the data showed that most of our patients who had TB, but the TB diagnosis is a bit delayed, especially in people living with HIV due to smear negative but culture positive HIV is culture positive TB is more prevalent among people living with HIV. So disengagement of linkage and also ART initiations is about 18% after they diagnosed with HIV. They may seen in either clinics started ART but defaulted subsequent follow-up. So there's a lot of factors involving this. Is either individuals in which they may have side effects of the ART or perceived lack of benefits of ART, or other mental health issues in which leading to defaulted. Interpersonal stigma is the one main reason why people worry to seek treatment, also do testing, and other factors including structural or clinics barrier. So what we have done, we have traced our defaulters, in which out of the 24 defaulters for the past 2 years, 2 of them have re-engaged care in other centers. We only managed to re-engage one of the clients. With the rest, we have uncontactable or have wrong numbers. So I think I want to emphasize not only for healthcare providers but our PT to encourage them to give a correct contact, so that if any issues we can contact our clients and give the appropriate care, and also re-engage them to care back. This is the algorithms in tracing the defaulters. Our HIV counselors will identify defaulter through clinic arrival records. We also had collaborate with our microbiologists to get the list of newly diagnosed patients, so that we can see their outcome, and maybe in futures we can see from pharmacy record for those patients who miss their ART refill for more than 2 months, we can contact them early, so to ensure they are still under the care. So beside tracing the defaulters, I think supporting our patients are very important. So this is the role of ID wellness, in which staff nurse Sakinah will talk afterwards. We're giving through education, counseling, patient-centered, and support them for adherence, retentions, and also linkage them to peer support groups. Some quality improvement to support patients so that they're retaining care and maintaining their health. So this is the WHO recommendations to strengthen the case kits. what we have so far, we have started rapid ART initiations, we have tailored special educations, we not seeing patients quite very frequent so that they can continue retains and also tracing the defaulters. We also hope we can improve this. We also started doing quality improvement and also enhance linkage with case management through our wellness clinics. We made Prof. Iskandar and also Dr. Ika had shown to us just now how we leverage the HIV testing through other measures, and also once I'm focusing at the hospital is by touching also decentralizations of care through committee-based organizations to improve ART initiations and also HIV preventions. So in summary, engagement across the continuum of HIV care dynamics is only not impacting individuals, as I demonstrated the earlier case, it also affecting the population's level of health. Systematic monitoring and engagement in care and adherence of ART is foundations, and the prognosis value of missed visit must be recognized, and our audit had highlights the critical area for improvement, particularly in ensuring access to care and also ART initiation and also comprehensive care to support them so that they continue engaged in care. Evidence-based intervention to improve engagement in care and also adherence to ART are amenable to and should be implemented in clinical setting, especially in our clinic, through collaborative efforts, not only among our ID physicians, but also primary cares, administrative, other healthcare providers, including the nurse, in which staff nurse Sakinah will emphasize the role of our nurses in supporting patients. And by taking the right path, we promote dignity, respect, and equitable access to healthcare for all individuals, reinforcing that everyone living with HIV has the right to receive quality care and support. With that, I thank you. I would invite every of you to join our World AIDS Day celebration tomorrow in Plaza UMMC, at the same time launching of our Tabung Bakti ID to support patients. So thank you.
Thank you very much, Dr. Sazali, for that overview of some very useful practical strategies that the unit sort of led by you and your team to reduce and disengagement in care, and initiatives which are evidence-based, such as rapid initiation of antiretroviral therapy. Moving on, and we have the last presentation. It's by Nurrul Sakinah, who is our HIV nurse counselor in the ID unit, and she's going to be talking about some of the initiatives led by her and her team, as well as the ID unit, particularly focusing around the ID Wellness Clinic.
Thank you, Prof. Iskandar. So I'm sharing my slide. You all see my slide, huh?
Yes.
Okay. Assalamualaikum and very good morning. My name is Nurrul Sakinah binti Asmawi. I am nurse counselor HIV/AIDS at ID Clinic. So my topic is last one, Wellness Clinic, introducing UMMC ID Wellness Clinic. So this is my outline. We'll be talking about HIV/AIDS nurse role, nurse counselor in UMMC, ID Clinic, then Wellness Clinic, nurse counselor, then my psychologist, criteria for counseling, activities in Wellness Clinic, statistic in Wellness Clinic, and future of ID Wellness, and last one, conclusion. Okay, for the HIV/AIDS nurse counselor role, number one, to educate patient on HIV knowledge after they have received their diagnosis. And number two, we are conduct comprehensive assessment of the patient physical, psychological, social, and spiritual needs. Then number three, to monitor drug compliance on NRT and related side effects to achieve an undetectable viral load. And then number four, to educate safer sex practice so as to reduce risk of HIV and STI transmission. Number five, to engage patient for retention in care to avoid loss to follow up. This one, we we follow up patient, we do screening, then we target the patient so that patient never default the treatment. And then number 6, to collaborate with multidisciplinary teams to improve patient quality of life. Then 7, last but not least, to collaborate with NGOs to empower patient self-management and increase social inclusion. The NGOs like CLASS, Kuala Lumpur Aid Support Service, PT Foundation, Heroes and MAC. And then collaborate with multidisciplinary, like here we refer them social worker or other things like skin or gastro to help patient. So nurse counselor in UMMC, now we have 10 nurse counselor in UMMC who have undergone post-basic nurse HIV/AIDS counselor training. So 7 in the ID ward for you, 2 sister and 5 nurse counselor. Now 2 nurse in ID clinic, medical clinic 3, and 1 sister in the other department. So in ID clinic, we operate medical clinic 3, ground floor there. So we got 3 sessions in a week. Monday, afternoon clinic 2 to 4, Tuesday 8 to 12, and Friday 8 to 12 p.m. Okay, now I talk about my clinic is wellness clinic. Wellness clinic. Hello, you listen to me? Okay, wellness clinic, we have 2 in charge, psychologist and nurse counselor. Okay, this is Clinic ID Wellness. We officially opening in December 2023. Wellness clinic operate 2 days per week, Tuesday and Friday. So nurse counselor and psychologists are in charge of this clinic. From 1 patient per day, now we are increasing to 3. And sometimes, because of many referral, we get 5 patients in 1 day clinic. 1 day clinic means from 8 to 12 p.m. This example of flyers. Usually when I give counseling to the patient, I also give a contact number. They want this contact number is ID wellness phone, so that if patient have something to do to change their appointment or they have any side effect, they will WhatsApp us so that we can entertain them lah and ask them what to do. So nurse counselor is at ID clinic is doing by me. So I see patient every Friday morning only. Tuesday morning I won't be see patient because we don't not enough staff now. So I hope after this, I hope after this many nurse come to ID clinic so that can join our wellness clinic. But because many patients come to get
Hello.
now. Hello?
Dah. Saya dah isi dah. Hello. Saya ambil tak silap 4 SL.
Hello?
Sebab dah ada tengok saya dah ada 50 kak. Ada cis tu.
Sorry, can whoever that is, can you silence your audio? I don't know who that is. Sorry, Sakinah.
Okay. So I continue my talk, yeah?
Yes, please, yeah.
The clinic code is now MD 28003. Before this, I use MD 28002. Means I sharing this code with psychologists. But we are moving forward. Starting this November, we separate the code so that easy for what staff and our club to give the date appointment for nurses or psychologists. So I have 1 counselor also in ID clinic, Standard Amida. She will be in charge for tracing defaulted patient at ID clinic. So wellness clinic, we do have psychologists, Mrs. Chong mainly, infectious disease unit UMMC with strong interest in HIV and mental health. As the very first psychologist working in the infectious disease unit of the UMMC, she worked closely with clinicians, nurses, and established the first infectious disease wellness clinic in Malaysia. That includes mental health care of care for people living with HIV. She's doing wellness clinic in every Tuesday and Friday. Her clinic will be set at ID Wellness Room at second floor near WP1 now, or in daycare room on Tuesday. The picture you just saw at Dr. Sazali's slide, that one second floor room for ID Wellness. So Tuesday clinic mainly we see patient who can come at Tuesday clinic. So only Friday morning, her clinic will set at ID clinic, same day with clinic ID. So mainly code clinic is MD28002. So pretty face here is mainly lah down here. So criteria for counseling. Yes, we are approaching new case. So new case patient, I can see overall 1 to 2 case per week or per month, maybe 4 case, new case is coming. So after we follow up with new case, patient will be steadily on ART. So we do pre-heart counseling. And then after they start the heart treatment, we will follow up patient after 2 weeks, they start the ART. So we will check their side effect or any problem with the medication. So that one I will schedule for the post-heart counseling. And then we catching up also for defaulters. Defaulters mainly they will come back after 1 year or 2 years, and then with viral load not suppressed more than 1,000. So I'm also receiving PMTCT, prevention mother to child transmission. We have a few mothers pregnant with HIV and without HIV. And also I done my counseling about 3 couple for premarital counseling. So we educate them how they want to do sexual intercourse if with viral load suppressed and without or viral not suppressed. So last one, psychosocial issue like medication. If they are failed for the first line, definitely they need for second line. Some second line need to add on cost. So we refer to social worker to help them to continue the treatment. So the activities like RVD education, this one mainly for new case, socioeconomic assessment, lifestyle modification, like before this they like to smoke, they like to drink, so they have to change their lifestyle because some of the medication may increase their sugar level or their cholesterol level. So I always ask them to do brisk walk, to take healthy food, and to take full cook. Okay, so medication compliance. So this one mandatory. They have to take medication like 10 p.m. Then they have to follow the time. And then for pre-exposure prophylaxis and post-exposure prophylaxis education, for STI, cancer, non-communicable disease, neurocognitive screening, mental health and substance use, like alcohol, smoking, recreational drug, screening and counseling. And then last one, screening of defaulter and re-engagement. So this is statistic in a month. So we operate about one year lah. So opening December 0. We don't have patient because we start in middle of the month. So we're getting patient 3 January and February 4 patient. In March, we have patient actually, but this one I not strictly ask patient to register. So I give counseling free lah, means they go to the ID clinic. So doctor refer to me and I strictly give the counseling without register. So we strict on that. So every patient must register. So the number is coming up lah. So October and November, more patients 66, and this coming November 71. So the MOs in the ward and also our pakar know about wellness clinic, and they are keep referring us. So future in wellness, counsel and promote vaccine for patient engaged in care and stable treatment. Vaccination like influenza, pneumococcal, so more patients stable. So like 2 times or 3 times coming to the wellness clinic, I will promote them for vaccine influenza or pneumococcal lah. This one to increase their antibody. So number 2, discuss and advise and conduct HPV screening using HPV self-testing for women. And 3, screen for and discuss mental health condition. This one, we are doing all patient RPD in our clinic. We go to the patient and we ask them whether they're interested to join for mental health screening. If they agree, then we register them for participant for screening lah. Okay, my conclusion, we have to support them to no stigma and judgment to them for patients who have HIV infection, because we don't know in future we are getting more and more patients. So to achieve 95% target, come join us to help us to consult them. So take the right path and tunai hak yang sama. Come join us tomorrow at WX Work Estate at Plaza Ruka at peringkat UMMC. Okay, thank you.
Thank you very much, Sakinah, for that presentation, really, which gives an overview once again of a nurse-led clinic, providing once again fairly comprehensive services beyond just around HIV care, but including areas such as comorbidities, non-communicable diseases, vaccinations, counseling, and working closely with with our in-house psychologists. Now, I'm aware it's time. I just like to, in my role as moderator, it'd be such a shame not to be able to address some of those questions which are in the chat box. Maybe I could just open up to questions to the panelists. Maybe take up an extra 3 to 5 minutes of your time. I hope the audience doesn't mind, but I think it's important to just be able to engage in some of those discussions. So if you could turn your cameras on, please. And maybe I could just bring out some of those questions which have not been answered. There seem to be a lot of questions around self-testing ICA, and I think I can see that you're trying desperately to answer those questions. And I think you may have just answered that. But I think some of the themes around questions are around sensitivity, and concerns around sensitivity. Are they as good as the other rapid test kits and compared to serological based test kits? And so maybe one question, how has HIV self-testing maybe changed community-based HIV self-testing, and is this still effective? And particularly around issues around anonymity and confidentiality, and in bringing people forward to getting tested. You were in the middle of typing the answer, I think. You're on mute, Ika.
Sorry, yes, I am. So I think that's a very important question to ask. In terms of confidentiality, in terms of providing anonymous, doing anonymous HIV self-testing, HIV testing. So in the case, I believe that this remains anonymous. But when you're doing this with community healthcare workers, it has to go through the MyBus system, through MySejahtera. So whenever you use MySejahtera, you always link this to your account, so it does not make this anonymous anymore, in a way that you're providing your details as well when you're doing this testing. But this is something that we're seeing the past few months or the past few, I think it's just less than 1 year. But I think there have been no issues on whether or not people would not want to do this because these are being captured. I think people are becoming more and willing to do this despite despite the need to provide their details through My Sejahtera. But because we're moving towards digital technology, and this is something that we cannot not go through. So I think I think moving forward, of course, these issues we would definitely see high levels of reluctance, but over time we can see that people are becoming more and more accepting of these methods.
Yeah. And, I'm a great support of HIV self-testing. I mean, I think it brings testing into home. I think issues around confidentiality, are less so when it comes to bringing testing. And it certainly encourages people to come forward. And certainly, as you've presented, the amount of women, even though they may be the worried well, who are coming forward to get testing is huge. So people who have previously not been tested before, which is what you're really looking at, it's an important indicator for HIV self-testing programs, are coming forward to get tested for the first time. The other question around HIV self-testing that's emerged from a couple of these questions is, there's still the need for pre-test counseling and maybe post-test counseling, but more so around pre-test counseling. You may have addressed it. If you have, I'm sorry about that. But I think we're sort of historically and traditionally very, we're taught that even as we move into more modern ways of testing, that there's a need for pre-test counseling, and self-testing essentially removes all of that. What are your opinions on that?
So we're moving away from doing counseling. I think I mentioned this in one of the comments. We're moving away, and it's being recommended by WHO because it's labor intensive. We do not have enough people to help us out to do the counseling. So now that we are leveraging on social media platforms, these can actually be used to provide information to people out there. So in a way, we are not dealing anymore with the need to have more, people to help us out with delivering this information, when this information can be easily provided on these platforms. And again, people are more tech savvy these days, and people are looking out on these social medias to get this information. So we are leveraging on these tools. Okay,
great. A question for Sazali, if I may. I think you've been very good at answering the question, so I can't really look at the second 95, and you did that towards it. How is the denominator, the first 95, determined? Do you know? I know this is probably a question to me, but would you know the answer to the question?
It's more towards the projections from our surveys, and also the how many key populations in Malaysia, and then the projections from calculations. I'm not really expert in terms of these projections, so I think Dr. Ika from Public Health and so more aware about the statistics. So it's more towards the projections than what we are expected, the numbers of people living with HIV in Malaysia. Yeah.
So could you add to that, Ika? You're on mute again, Ika.
I think we need more data to help us do the projection. I think it's kind of early to say anything about this. So definitely we need, if anyone's interested to do modeling, there's always trivia, and also the Malaysian AIDS Council to approach and look at ways how we can do projections.
Okay, great. There's a question on dolutegravir, and if I may, I would like to take that question. It says, the question is, dolutegravir has been approved to be prescribed by FMS in KK. That's actually very good. I did not know that. I knew that was coming, but that's I didn't realize that was happening. However, cost is an issue, and it's still considered the second-line treatment in our local guidelines. I believe the uptake would increase if the guidelines change, just like changing from Combivir to Tenvir EM. And is there any plan to do so? So I'll take the first part of the question, and Sazali can back me up. So the question is, in the Malaysian guidelines, dolutegravir is a preferred treatment as alongside efavirenz. So in our practice, and that's also reflected in our practice, particularly in UMMC, that when a patient comes to us for the first time, we give them the option of either prescribing dolutegravir or efavirenz-based regimen, and really leaves it up, and we leave it up to them, and we go to the pros and cons of each treatment. Now, of course, cost is an issue because efavirenz is available free in UMMC, but dolutegravir isn't. Until the price goes down, it is probably not going to be available free, but there are subsidy schemes to support patients on this. So my answer to your question is, it is in the WHO guidelines to support it as a preferred first-line treatment. It's also in the Malaysian guidelines as a preferred treatment, as an alternative to efavirenz 400 or 600. And I just checked that just to make sure that I'm not lying to you. So I think it's, generally with Ministry of Health is always down to cost, and unless the cost goes down, it is not going to be reflected in clinical practice. But that is a space which is going to change, hopefully, very soon, I am told, after further engagement with Ministry of Health as well as the MPP. Okay, now we're 9:10. Do we want to continue, or do we feel that we need to say goodbye? What do you think, Sazali? Do you think?
So maybe I just want to answer one more question about the resistance among people living with HIV, especially PV in primary care. So I think the main issues with them, there are a lot of social issues and so mental health issues leading to non-compliance and subsequently affecting the viral suppression. So by supporting them, engaging them in care with what's, for example, our HIV counselor and so wellness, and supporting them so to identify the factors leading to non-compliance, which is always helpful, that improve the outcome. And also dolutegravir, which is very high resistant barrier to resistance, will improve this and also reducing the risk of HIV resistance and also virological failure.
Yeah, no, absolutely. Actually, I saw that question and I should have brought it. I'm sorry I didn't. Actually, I cannot possibly end this without having a question for Sakinah. Sakinah, can you put your camera on, please? Thank you for your presentation. Thank you for doing it in English. You didn't have to do it. And I know that was certainly, a major achievement on your side. So thank you for that. Now, I just basically, my question to you is a bit complicating, but in the sense that, setting up these nurse-led clinics can be quite difficult in UMMC because you are taken away from your other jobs, and we want to promote more of these nurse-led initiatives in specialty medicine across UMMC as a way of task shifting, but also building on the expertise and capabilities of nurses. So I was just wondering, and this might be, I don't think it's a difficult question, but some of the lessons learnt that and that you can impart on maybe advice to other specialities about nurse-led clinics in terms of the support that you have got from the higher nursing and the matrons, which I know you have, but this has taken a long time to set up. So maybe could you answer that?
Cannot understand Prof.
Cannot understand me. Oh goodness, cannot understand. So this. Okay, let me. So this setting up of nurse-led clinics in specialty clinics across UMMC is not new, but it has been a process to happen, and it hasn't been easy.
Yeah.
Would you agree? So I want to just if you could impart, maybe in 1 or 2 minutes, some of the lessons that have learnt and some of the advice that you maybe can impart in terms of, and tell us in terms of, so things like maybe you have a dominant ID person pushing this, or you have a very supportive matron, so that this continues to just grow and get bigger and bigger.
Can I answer this in Malay?
Boleh, of course. Yes, please go ahead.
Sebab wellness clinic ni dah about 1 year. So we are getting more patient. So nursing, because we lack of nursing in PPUM, and of course outpatient clinic, kita punya nurses memang tak akan dapat penambahan because of shortage of the staff. So our role is we want all the ID clinics nurse to be one side, so that we can together see patient in clinic or in the ward. So kita punya aim, we'll see patient in the ward and clinic. So like nurses in DCU in stoma nurse, because they got one side office. So when they refer to them, they will go to the patient to see patient in the ward or in the clinic. So yeah, our matron need to know our objective lah. Maksudnya kita punya objektif, matron kita kena tengok, and then maybe ada penambahan staff, so that akan berjaya lah kita punya wellness clinic ni. Because now I stand alone dekat klinik, I with my friend lah, Standard Amida. Sometimes because in wellness clinic saya seorang saja, so maybe saya perlukan seorang lagi untuk bantu saya in situation yang contoh kalau saya EL ke, saya ada emergency ke. So kita ada patient, bukan kita tak ada patient. We got many patient. So kalau contoh kalau saya ada hal, saya terpaksa ubah jadual patient saya pada hari itu kepada hari lain kerana tiada nurse counselor yang cover that time. So why not tambah lagi the nurse HIV counselor in clinic, so that we can see more patient lah. So we are registered patient, and yes, kita dapat pendapatan daripada wellness clinic tu jugalah, means kita bukan bagi kosong. Yeah. Then to achieve target 95% tu, kita kena buat wellness clinic. But I tengok banyak defaulter, patient yang setahun, 2 tahun datang balik. Dan macam mereka rasa memang tak boleh. Kadang-kadang bila dah makan ubat ni, mereka dah rasa sihat, mereka tak nak datang ambil ubat dah. So bila mereka jatuh balik, patient yang akan datang dan jumpa untuk set appointment. Masa tu maybe first line dah tak boleh bagi dekat patient, kita kena tukar kepada second line ubat. So kita tak nak macam tu. So kita nak patient kita first line dan zero defaulter lah dekat TPM ni. So untuk itu kena ada penambahan staff dekat klinik tu sendiri, sebab klinik ID wellness ni bersama-sama dengan klinik medical. So kita agak besar lah kita punya team ni, lebih pada 16 disiplin. So dengan ada penambahan nurse lagi di sini, boleh berjayakan program ni lah, Prof.
Okay, thank you very much, Sakinah. And so that's a clear message to the powers that be in terms of nursing and matrons, that there is a need for an increased number of nurses in these nurse-led clinics, and hopefully support. But we have got so far an incredible amount of support from the nursing team. So I just want to thank the matrons already thus far. So I think we've come more or less to the end of our session. Thank you very much for hearing us out with the number of presentations that we've had across the different 95s. And thank you for the questions. I think they've reflected, there's a lot of interest obviously in HIV self-testing, and also, Ika, that's also maybe, it is so maybe just focuses where some of our work should also concentrate maybe in the future, obviously based on the amount of interest in there. And thank you for other speakers for providing practical strategies and on reducing disengagement. So I think once again, just wishing everybody a happy World AIDS Day, and I will close this session, and we look forward to meeting with you tomorrow as our part 2 celebration of World AIDS Day. Big thank you from me and from the presenters as well. Thank you.